Thank you very much, Mr. Chairman, distinguished panelists, dear colleagues. It's, again, an honor to be here, and congratulations again on a wonderful and successful conference. So we'll talk about management of aortic regurgitation with some focus on off-label indications, but also we'll touch a little bit on dedicated devices for AI. I am a proctor for TAVR for Medtronic. So native aortic valve regurgitation happens up to about 2% of the population. And in indicated patients, surgical repair or surgical replacement is the recommendation in the guidelines. TAVR has emerged as an alternative for high-risk surgical patients and accounts actually for about 40% of what is used off-label for these devices. So this is a very interesting paper. It's fairly recent, but again, it reminds us about that symptoms are one of the clear indications for intervening on severe aortic regurgitation, but there are other parameters, mostly echocardiographic, and as you can see here, the 50-50 rule, but as you can see, things are now evolving into GLS, global longitudinal strain, and the indexed parameters. Those are the indications to consider intervening on AR. TAVR and AR is challenging because the devices were not designed to manage the conditions and the anatomy for aortic regurgitation. The annuli are large, and you usually have associated aortopathies and dilations. There's lack of annular calcification, nowhere to anchor the valve. The valves are designed to actually sit in tight, calcified valves. The larger stroke volume and the regurgitant volume cause a suction effect. So as you land your valve and you start to deploy, there's a lot of movement that does not allow you for proper positioning. So it's not uncommon to see potential complications, high rate of PVL, migration of the device, embolization is one of the serious complications there, needing a second valve, pacemaker implantation, and unfortunately, there is an associated mortality in certain patients. So this is one of the interesting early papers, actually looking at the use of TAVIs before dedicated devices in severe aortic regurgitation. This is an example of a very dilated aortic root with severe AI, and this is an example of a previously repaired dilated root with challenging anatomy to actually get to the device to the proper location. Lack of calcification actually is present in about 90% of these patients, and is strongly associated with the need for using a second valve, which is migration or embolization of the primary valve. It is associated with improvement in New York Heart classification. Interestingly, the procedure success is about 75%. So you walk in knowing that 1 in 4, 1 in 5 patients will not have a successful procedure. Some of the tricks described is to put 2 pigtails in appropriate cusps and use that instead of injections to land your device. This is an example of a first TAVI device that embolized, they snared it, and they deployed a second one, anchored actually by the first snared device. One of the indications that actually has emerged as a use for TAVI is patients with VADs. As you can see here, this is the VAD pump, and if you run the pump at a high RPM, you have aortic regurgitation both in systole and diastole, which is a significant problem for the ventricle. If you decrease the RPMs, you see it in diastole only, and after you implant a TAVR, then the AR is completely gone. This is the device, this is the landing of the TAVR, and this is it deployed with no significant regurgitation beyond that. In this series of 11, they had 1 mortality that was actually in the case of migration and embolization of the TAVI that ended in an unfavorable outcome. This is the Emory experience, looking at aortic valve surgery versus transcatheter for isolated AI. This was a registry, so selection bias has to be considered in this group. So they had 454 patients for surgical and 39 patients for TAVR. And as you can see here, 50-50 split between SAPIEN and self-expanding Evolute core valve. Mason mortality were not different, but as you can see here, there are better hemodynamics actually with the TAVIs as compared to the surgeons. With the TAVIs, you pay the price with a higher need for pacemaker implantation, and with surgery, there is a more common peri-procedural, peri-surgical atrial fibrillation. The Pantheon registry is a registry looking at the use of TAVRs and AI. And again, we talked about the potential challenges, the annuli being large, lack of leaflet calcification, left ventricle dilation, and these are the two platforms that are used. One thing to remember, post-dilation has been linked to migration and embolization, so this is recommended to be avoided. And it's usually not needed, really, because you're landing a super or oversized valve in an annulus that is not really calcified. In this series, they looked at the self-expanding was about 2/3 versus the balloon expandable. And again, you can see that the device success is about 75%. So these are not a high-yield kind of procedures. When you see here that the mean gradient actually is better with the self-expanding valve. Predictors of valve embolization, we talked about post-dilation. Again, strongly recommended to be avoided. And if you do have valve embolization, you can snare it, put another valve, reposition using a balloon inflation, which is quite challenging if you've had to face that situation. Conversion to surgery and aborting the procedure are also other options. Again, more of the same. You can see here, embolization is higher and, well, not really different. Between the two platforms, most of the outcomes are the same. Important to remember that embolization happens about 12% of the patients, and the predictor is post-dilation. Shifting gears, there's a voice that comes with this. I apologize if it's not playing, but this I put there in there to remind me that there are other things in life beyond medicine and beyond TAVRs, and also to break the monotony of the presentation. Does anybody know what this car is? It's okay. We'll talk about it later.
Which Ferrari?
It's a Ferrari. It's a Ferrari 250 GTO.
Nice.
Yes. So dedicated valves for aortic regurgitation. Now that we've seen that AI can be treated with TAVRs, we've now come up with designs to allow us to dedicate certain designs, certain devices and platforms for these patients. So the JenaValve was the first, and that's the first generation. You have locators that actually sit in the cusps and clip or position themselves into the leaflets. This is the second generation, the Trilogy. It's a transfemoral approach, and as you can see here, the locators sit in the bottom of the cusp, are very close to the leaflets, and then you deploy the valve and anchor it that way. That way it's better positioned and it's more likely to stay where you intended it to stay. The Align AR was the study looking at the Trilogy transcatheter valve, and this is the early experience. This was about 180 patients, and as you can see here, this is the way you deploy it. You come in, you land at the bottom of the cusp, you deploy the valve, and these are the allowed sizes. Very acceptable clinical outcomes, as you can see here, but more importantly, very favorable LV remodeling. You see decrease in LV size and decrease in LV mass, and most of the cases, you have no significant aortic regurgitation after the procedure. This is the 700 patient experience with the Align AR, and as you can see here, very favorable remodeling parameters. Hemodynamics are excellent. Valve regurgitation is minimal after the procedure, and significant improvement in New York Heart classification. The J-valve is the other device, and this is first in man reported. And as you can see here, these are the echocardiographic parameters with the paired cohort, significant improvement in parameters. But the advantage of the J-valve, it comes in very large sizes to accommodate very large annuli. So this cohort of patients or these sizes are not available with the JenaValve. So this is the advantage of having the J-valve. And the way it sits is that these are the locators, again, and you advance it there. You start deploying. It is a self-expanding valve, and in this case, they actually did a post-dilation to better oppose the valve to the annulus, and they ended up with no significant aortic regurgitation. The last study we're going to talk about is a meta-analysis comparing dedicated devices versus off-label devices. And as you can see here, one of the significant parameters they looked at is significant reduction in valve embolization with the dedicated valves as compared to the off-label valves. And the outcomes are significant. All-cause mortality was better in favor of the dedicated devices. PVL or remaining aortic regurgitation, embolization is less with the dedicated valve, need for intervention, need a pacemaker, all are in favor of the dedicated devices. Remember to always look for large valve size, clipping of the leaflets with the locators, rapid pacing to avoid the suction effect. The device success, usually with off-labels, is between 75, as we mentioned, 80%. Now it's up to 93%. And again, mortality is very, very low, significantly lower in the dedicated devices. So in conclusion, aortic regurgitation poses anatomical challenges for TAVI, but there is room for it in high-risk surgical patients. There are associated complications that we talked about, and there are ways to avoid them. Early experience with non-dedicated off-label devices have been suboptimal, and the new dedicated devices now offer a better option with improved outcomes. Trials are ongoing, and results are promising. So stay tuned, and hopefully we'll have some more data to present in the near future. Thank you very much for your attention.